Yeah, we have started.
You started?
Cautiously. Yeah.
Very good. You're a little dark, huh?
It will dark.
There is a background is more bright. Now, if you just tilt the laptop, that will be better.
Yeah,
Better.
Yeah, yeah.
Still, the background, there is a lot of light from that window.
I should close that. I should sit somewhere else. I'll just pick up my laptop.
Just turn, sir. If you, opposite side is better.
Yeah, that's better.
That's better. That's better.
Okay, so we are live. I'm going to go to the disclaimer slide. And good afternoon, everybody, and welcome to the online education webinars. We'd like to thank all our faculty for sharing their knowledge and expertise in this challenging times. We wish all our audience a healthy and safe day ahead. And we hope these webinars add value to them. These webinars are dependent on a lot of technology and internet speed. So please bear with us if there are any issues with that. So over to Dr. Nilen Shah for moderating the event. Over to you, sir.
Thank you, Ashok. A warm welcome to all from the faculty and also for the audience who I hope has joined us. These long days of Corona is taking a toll on all of us, but hopefully these days are limited and we will get back to our OT and theaters and operating and patients. And hopefully we should not have unhappy patients, which I believe is an occupational hazard for us. Can you all see the slides?
Yes, sir.
Okay. So let us understand what is an occupational hazard. An occupational hazard is a risk which is accepted as a consequence of a particular occupation. Now, we all are knee arthroplasty surgeons, and if you look at the literature, various articles would say that between 8 to 28% of the patients who are operated may be unhappy. But generally in surveys, this figure seems to be between 18 to 20% patients. This is Western literature. We all like to pat our backs and we believe that our results may be between 5% to 10%, but there is no solid data to back this claim. And our figures also may be higher and hopefully could be lower as well. In these 2 months that we have spent at home, at least what I have spent at home is akin to the summer vacations that we used to have. And before the days of internet and Netflix, there were comics. And I remember reading Phantom comics. So there is an old jungle saying which says that you do not find the phantom finds you. And I thought of coming out with a surgical saying, which is you do not find the unhappy patients, they will find you. So patient satisfaction after a knee replacement is a huge subject. Depends on patients' expectations, pain relief, and functional improvement. There are patient-dependent and patient-independent factors. The dependent factors could be the age, the gender, the degree of arthritis, the personality of the patient, the comorbidities that the patient has. And the patient-independent factors are what type of anesthesia has been administered, multimodal pain analgesia, which type of surgery, what implant, etc. There are various tools to assess this. The Knee Society score, the modified Knee Society score, in which satisfaction, expectation, and physical activity is also taken into account. The WOMAC score, the short form 36 and short form 12, the Coos score, which is the knee injury and osteoarthritis outcome, and the Oxford knee score. The causes for patient dissatisfaction, one major factor is residual pain, limitation of function, unmet expectations, psychological issues, and need for resurgery. And I may add that one other cause is if the patient meets somebody who is perceived to be doing better than what our patient is and has spent lesser amount of money than what our patient has had to get the same result, the patient will feel dissatisfied. So comparison with peers becomes a major point. I was just looking at some happiness surveys also, happiness index, and it was generally said that the higher income that a person earns will be able to make that person happy, but only to a certain limit. Beyond a certain limit of income, which all my faculty members are enjoying, and the audience is also enjoying, further income does not make the person happy. What makes the person happy is how he's doing in comparison to his neighbors, peers. If he believes that he is doing better than his peers, then the degree of happiness is higher. We need to look at certain warning signs preoperatively to find out the patients who may not be do so well after surgery. So somebody who is complaining of a lot of pain at rest. Mainly, as we know, arthritis is a biomechanical problem. So we are good at fixing mechanical pain, the pain that comes on with activity. Pain at rest may be there, but we need to assess it a little bit closely. Then if a person is complaining of pain in other joints, which to your examination and findings appear normal, if a person is complaining of pain all over, then you need to be careful. Then there is this term called catastrophizing. I'll just come to that. Then also you need to be careful. And if a person appears to be unduly anxious or depressed. Now, what is this pain catastrophizing? It again goes into three parts: magnification, rumination, and helplessness. If a person says that something bad is going to happen, if he is afraid that the pain is going to get progressively worse, he cannot think of any other event, then this is magnification. Rumination is that they can only focus on the pain and they can't think of anything else at all. And they keep on thinking how badly they want the pain to stop. And if there is a degree of helplessness, if they believe that they can't go on, they can't stand it anymore, there is nothing that they can do to reduce the intensity of the pain, it is terrible and nothing will make it better. All these factors tell you that the patient's mental state is not as well as you and I would like it to be. Then we need to avoid unmet expectations. So to do that, firstly, we need to know what the expectations are. And to do that, we should be prepared to spend a lot of time with the patient preoperatively so that we as well as the patient are on the same page. And the other thing is we may underpromise and overdeliver so that the patient's expectations are comfortably met. There was a study by Robert Bowen, which is very often cited, that unmet expectations is the strongest correlation of dissatisfaction. It is even 5 times higher than having a complication. There are internal determinants of patient satisfaction. Age. There are a lot of studies which say that to satisfy younger patients is difficult. Gender. It is said that female patients may have slightly greater degree of dissatisfaction. as I said, personality, anxious and depressed patients will have further problems with knee replacement. Expectations, we need to rationalize. If the person is having comorbidity, if there is an associated hip arthritis or spinal claudication, and you do a knee replacement, the degree of satisfaction is likely to be lower. Then type of arthritis and the severity of arthritis. Rheumatoid arthritis patients are generally the happiest because knee replacement reliably relieves pain, and rheumatoid arthritis patients have suffered pain for a considerable length of time. If you operate on patients who have minor symptoms, severity of arthritis is grade 1 or 2 on the scale, then the likelihood of those patients becoming unhappy after surgery is much, much higher. And you also need to see that whether the patient has support systems. If the patient has a loving family around him, then the likelihood of that patient doing well is higher. Elderly patients, patients who are living alone, patients who are poor, studies have shown that these people have higher degree of dissatisfaction after knee surgery. The external components of patient satisfaction is anesthesia. There are reports which say that spinal anesthesia or regional anesthesia may be better. Host of pain relief techniques, which I'm sure all of us are following. And the pain relief has really changed over the last few years. So multimodal pain analgesia techniques definitely helps in satisfying the patients more. The surgery type and technique, we had 1 or 2 webinars on this. So these also are points are important for patient satisfaction, but they are heavily debated. What implant you put in has some bearing, but again, there is a lot of controversy about this. And post-op rehab, if they have good rehab, then the patients tend to be happier. But again, some reports have shown that even without a dedicated physiotherapist, the patients can do as well. There are certain fundamental tenets which I believe, that there was a prayer which said that lead me from falsehood to truth. So the surgery prayer for me is what to do and what not to do. Lead me from darkness to light. So teach me how to do and how not to do. Lead me from death to immortality, when to do and when not to do. So the issue is how to avoid creating unhappy knees and how to manage them. I believe failure has many masters, but success has only one, which is exceeding the expectations of the patient. So failure may occur because of problems in diagnosis, planning, execution, and management. We should be offering surgery of knee replacement only when the patient's symptoms, the clinical findings, and the imaging, they all collate for us to get a foolproof degree of knee arthritis, and only those patients we should be operating. If these findings are not coming together, like in this Venn diagram, then we should hesitate to operate. We should rule out spinal problems, hip problems, vascular problems, neurological problems. We should listen to the patients so that we get a good idea of the patient's expectations. I find this compression test very, very useful, and I'll come to that. But what we are looking for and what we are good at eliminating is bone-on-bone arthritis. So this compression test or the grinding test for medial OA, you put the leg in a figure of 4 position. The examiner's palm rests on the medial joint line. Flex and extend the knee, applying pressure on the medial joint line. If this reproduces the main pain that the patient complains of, then this is, and the x-rays are also coinciding, then this is what is due to medial OA, and this will be well relieved by surgery. For lateral OA, obviously you will pressurize on the lateral joint line. And for patellofemoral OA, again, you can do a grinding test or a Clark's test. to elicit the pain that the patient complains of. If the pain does not get elicited, then you need to think again. You need to tell the patient that this is the pain which will go, and the other pains may not go after surgery. This is an interesting slide which shows that if you operate in early stages of osteoarthritis, you may get unhappy patients. So if supposing somebody has just developed avascular necrosis in his medial femoral condyle, so on the whole he's enjoying good health, then his health has deteriorated because of this, and then you operate, then he becomes better, but the perception is that he has still not achieved normalcy. So he still feels unhappy. On the other hand, if you operate on somebody who has had advanced degrees of arthritis, his health has deteriorated over a period of time, and then when you operate him and his health improves, then there is a definite positive perception, and despite the artificial knee not giving him an absolutely normal function, he will be happy after the surgery. So beware of operating patients with very short duration of symptoms. This is a very, very old principle that if you fail to plan, you plan to fail. So look at this case, broken implant inside the tibia, varus which is there. So did an osteotomy, removed the broken implant, a long stem unconstrained total knee with fibular osteotomy and grafting at the osteotomy. So patient was fairly happy with this. Then the second thing is execution. You may plan, but you need to be able to execute that plan well. If there is something going wrong, you need to have a plan B. If you are starting off in your surgical practice, you need to arrange for some kind of a support system, that if you need help in theater, who would you be able to call? So again, that needs to be organized. If on the other hand, you find that the problem is such that it is unsalvageable, then you need to stop, explain to the patient that some unforeseen problems have arisen, and you have to come back another day with more preparation to settle the issue. What you don't want to do is do something which you regret later on. The management needs to be medical, which we all talk about, but in the Indian setting, the management also needs to be social and economic. We need to work in the best interest of the patient visibly. The patient as well as the relatives should be able to see what we are doing. Now I'll share a case of a 58-year-old gentleman, 2 weeks post total knee. He had a major fall on the road. He was non-diabetic, morbidly obese, and this was the photograph that was sent to me about this patient in one of the hospital's casualty. I was able to get him on table within first 6 to 8 hours, called the plastic surgeons, did a flap. After 5 days, no infection, and the wound was skin grafted as well. And he started mobilizing in a period of 4 to 6 weeks. So despite having such a major catastrophe, this patient was still happy. So having the complication may not be a problem. How well that complication is managed will decide whether the patient is happy or not. We need to be on the same side as the patient and the relatives. So the management needs to be social, and we need to be empathetic and eager to look at the economic expenditure of our patients as well. Now, to judge satisfaction, in a lot of commercial establishments, there is something called as a net promoter score. That means you've provided some service and you try to find out how many people are net promoters of your service. Even this can work for air conditioners, laptops, for anything, phones, that how many people are happy with what you have provided, and how many people are unhappy How many people are detractors of your service? Obviously, there will be some people who will be fence sitters. So the net promoter score is promoters minus the detractors will give you the net promoter score. And friends and family test, I think this has been incorporated by the National Health Scheme of UK in a big way. And I find that that is very, very interesting that you do, supposing you do a surgery, even a carpal tunnel decompression or a knee replacement for a patient, how many of the friends and family of that patient who's undergone that surgery will promote or detract from having it from us or from our establishment. So if our friends and family test is good, that means the patients are getting satisfied with what we are providing. So this is a simple test and I find it is very, very good. Now, obviously, if things have not gone right, then there may be some reasons for resurgery. The implant may loosen, may be unstable, there may be sepsis, there may be extensor rupture, there may be patellar issues and malrotation, the knee may be stiff, periprosthetic fractures, or breakage of the implant. Obviously, we want to avoid these complications, but when you do come for resurgery, you need to put the reason as to one of these, as to what has gone wrong. And if you cannot diagnose it, do not operate, because revision surgery without a specific diagnosis does not work well. Now, we need to be aware of costs also. So there is this concept of value, which is the health outcome plus the patient's experience divided over the cost of delivering the outcome. As you can see, as the cost of delivering the outcome keeps increasing, the value may decrease of what we are providing. So in conclusion, I would say that technically we need to do a good job on the right patient with realistic expectations at the right price, and then we can move from patient satisfaction to patient delight and decrease the number of our unhappy patients. I thank you for your attention. And I will stop sharing my slides. We will have the question answer session later on.
Yes, sir. Thank you, Dr. Nilen Shah, sir. And sir, who's next? Who shall go next, Dr. Nilen Shah, sir?
I think if we could ask Dr. Anup Jurani.
Very well, sir.
To talk
so
about.
I'm sharing my screen here.
Yeah.
Can you see my screen or no?
Yes, sir. I can see your screen. We can see your screen.
All right, great.
Yeah.
Right, so we're back to business, and I think our main business is to create happy knees. And I'll be talking mostly of one particular set of unhappy knees, which is painful and stiff. So mostly stiff total knees. First of all, the definition, and what's the new definition? In 2016, the International Consensus on Fibrosis of the Knee Joint gave this new definition. So 10 to 90 is mild stiff knee. This is post-TKA. 20 to 80 is moderate. And more than 20 FFD and less than 70 ROM is severe. So what we see most often is mild to moderate. Somebody having a 10 to 20 FFD, 80 to 90 ROM is really an unhappy patient if he keeps on having that kind of deformity and pain 6 months post-surgery. This, of all the unhappy patients, of all the post-op problems that we have, occurs in about 1 to 3% of cases in current literature. But I believe it's more because the registry data does not capture stiffness as a cause of failure. So it is definitely more. So Oh, yeah. Okay. So what are the pre-op causes? The pre-op causes could be mostly inflammatory, post-traumatic arthritis, a pre-op limited range of motion, and diabetes and smokers. So people who take insulin on the thigh are more prone to develop stiffness. That's been shown. Smokers form more fibroblastic tissue and scar tissue. Patients who have a tendency to have keloid formation are also more prone to getting stiffness and inflammatory knees, of course. Somebody who starts with the inflammatory knees or a poor range of motion or already stiff knee, a tight knee, is prone to developing a stiff knee. I think patella baha is really is unrecognized or under-recognized caused as a precursor of a stiff knee. So these patients can have normal range of motion. So you can see there is severe patella baha, but the range of motion pre-op is normal. But this is a patient who's likely to develop a stiff knee, at least in flexion, if we don't recognize, treat, and tackle patella baha efficiently. There are a few things that we need to do and we can do for patella baha patients. If they don't have FFD, we can cut less of distal femur. So we don't elevate the joint line, and we can compensate that on tibia with less slope or cutting more tibia. Cutting less distal femur is one. Two other small tricks are to use a high flexion poly. Now, high flexion poly does not give high flexion. I don't believe it does. But what it does is that high flexion poly has a high chamfer at the front, which prevents the impingement of the patellar tendon to the poly or patella to the poly. And third small thing that we can do is to superiorize our poly button. Take one size smaller and superiorize the poly so that the patella baha you can treat by doing these three things. And you can see here that we have kind of got the patella to where it belongs, because if you have a patella baha, then the patella is going to hit the poly or tendon is going to hit the poly, and you will get range of motion 90 to 100 and an unsatisfied patient. So best thing is to do resect less distal femur, superiorize the patella, use a high flexion poly, prevent impingement of the patella on the poly, and hence prevent a stiff knee in flexion, at least for patients starting with patella baha. There are certain other red flags. Post-traumatic cases, like you can see here, somebody with multiple scars will be very stiff, soft tissues will be scarred. We need to really release, clear the gutters. And severe deformities, so it's patients who are ankylosed or fibrous ankylosis, who are starting like 20 to 60, 20 to 70, are at a high risk of developing a post-op stiff knee. So first we'll talk of certain tricks to identify these patients and counsel them properly, and as I showed, to treat patella baha, do some tricks on the table to prevent stiffness, because I think prevention is possible for these patients. This video is not running. Yeah, okay, now it is. Now, the aim of, oops, sorry for that. Let me run my video and then again, I think I'll again go on the slideshow. Now, the point I'm trying to make here is that you need to get full extension on the table. Never come out of the table by leaving the knee in 7 to 10 degrees of flexion and believing that that patient will get full extension through physiotherapy. That's not happening, at least in a male patient. So ensure you leave every patient in 2 to 3 degrees of flexion, so when the patient weight bears, he is nice and neutral. Second, don't leave the table without giving 110 minimum flexion on the table. So these are two things that you can do. Don't come out doing that. Don't leave the patient in 10 degree FFD and 90 degree ROM. That's a tight, stiff, painful situation, and that patient will really be very unhappy. So you can use technology. Experienced surgeons know how to get full extension and reasonable amount of flexion. But I think the point that I'm trying to send home is that getting the patient fully straight, nicely stable in extension is so important to prevent a stiff knee in extension, and getting 110, 120 degree of flexion is so important to prevent stiffness and flexion. Now, it's important that we get the patient this kind of sagittal alignment, every patient, and not not depend on physiotherapist to get us this. This the patient should get 3 weeks after stitch removal. Every patient should be fully straight, absolutely perfect straight in sagittal plane. And patient should get at least 100 and 110 degree of flexion, even those who start with stiffness. There are things that we discussed that you can do to get the patient at least 110 degrees. If not 130, 120 is ideal, but at least 100, 110 is minimal for ADL. Now, let's come to certain intraoperative factors. What things can go wrong? So flexion, extension, gap imbalance is the commonest thing that can go wrong. Somebody who cuts less tibia, cuts 6 millimeters, put a 9 poly, bad situation, until unless the knee is very lax. So flexion, extension, gap imbalance is truly a recipe actually for getting a stiff knee. So never do that. Overstuffed joints and excessive joint line elevation with this stuff. Don't overstuff the joint. Don't make it tight. The metal and the poly should replace the removed bone. If it's more than the removed bone, until unless the knee is extremely lax, that's a sure disaster, and that will be a stiff and painful knee. A very large prosthesis, especially the old generation prosthesis, which had only 5 sizes, you take a bigger size, and if it impinges on the medial lateral soft tissues more than 2 millimeters, that's a recipe for a painful stiff knee. Let's come to the sagittal plane. That was the coronal plane. The sagittal plane, upward slope, femoral component in flexion, or oversized femoral component in the sagittal plane, all this is also indicative that you are heading towards a painful stiff knee. What about axial alignment? We discussed coronal, sagittal, now axial. Patellar maltracking, subluxation, dislocation will be a precursor for a stiff knee. Overstuffed anterior compartment. Never leave the patella thicker than you start. Actually, you should thin it by a couple of millimeters. So don't overstuff the anterior compartment. That knee will be stiff in flexion. And respect the synovium anteriorly. If you don't, you'll find HO there and quadriceps excursion failure, and that patient will be stiff in flexion. Post-op factors. Now, those are intraoperative. We discussed preoperative, the red flags, how we handle them. Peroperative issues, coronal, sagittal, axial malalignment. Post-operative, I'm leaving infection aside because that will be covered by either Dr. Jahangir and by Dr. Rajesh Malhotra. So poor pain control, suboptimal post-op rehab, and hemarthrosis. These are 3 things, and unrecognized periprosthetic fracture, medial condyle or supracondylar, are again some things that can lead to a painful stiff knee. Now, we often say whenever we see a patient 10 to 90, that this patient has got arthrofibrosis. What is truly arthrofibrosis, and how can we differentiate it as a true reason for that patient's stiffness? So bands of scar tissue between the cord mechanism and the femur, and these bands of scar tissue prevent excursion of the cord mechanism and limits range of motion. How do we recognize this? Good patellofemoral mobility in a stiff knee suggests a balancing issue and not arthrofibrosis. If you have arthrofibrosis, your patella won't be freely mobile on the femur. So if you have good patellofemoral mobility in a stiff knee, that suggests a balancing problem and not arthrofibrosis. Now, what we need here is, this is how a scar tissue is formed. So connective tissue heals themselves by forming scar tissue. Whenever we incise the knee or incise tissue, tendon, anything, it will heal like this. First by neoangiogenesis, then by proliferation of fibroblast. And if there is any stimulus for excessive proliferation of fibroblast or the scar tissue, it could be smoking, it could be diabetes, it could be poor surgical technique, it could be rough handling of the tissues, it could be excessive use of the cautery. All of these things cause trauma to the tissue, more fibroblast formation. If you don't handle the soft tissue, however good you may handle the bone, that knee is going to be painful and stiff. So respect the soft tissue. And as we have been discussing in the previous few seminars, limit the use of tourniquet, be very gentle with the soft tissue, don't be rough on the synovium, handle everything very gently, prevent fibroblast proliferation as much as you can, give good cocktail anesthesia, and do all that we've discussed till now. Now, if you have your own patient or any other patient with stiff knee, so let's say 10 to 90 or 10 to 80 is the commonest presentation. How do you manage the patient? So first 6 weeks, mobilize the patient. 4 to 8 weeks, you can manipulate under general anesthesia. After that, from 3 months to 6 months, you can do open/arthroscopic lysis of adhesions. And after 1 year, if it's not healing, not relenting, then we can do revision arthroplasty. Now let's discuss these management principles one by one. First, mobilizing the patient. So patient seen at 6 weeks, you do adequate pain control. CPN is not going to help, and over dependence on physiotherapist not going to help. If you push the physiotherapist, they're going to make it worse. They are going to do aggressive physiotherapy, and that's going to cause breakage of scar tissue, and that's going to be worse. So don't push the physiotherapist too much. Initially, rest, ice compression, elevation, and physiotherapy. So those are the things that you can do initially when you see a patient, unhappy patient, stiff knee, yours or somebody else's. Call that patient for weekly follow-up. It's very important. Then the second thing is manipulation under anesthesia. So 6 weeks to 3 months, manipulation has been shown. I haven't manipulated any of my patients, but people do it. If you see a patient, there is no harm, but we'll discuss the principles. Manipulation you should do under intra-articular injection, preferably under continuous epidural. You admit the patient, do manipulation, let the epidural continue for 2-3 days, and continue mobilizing the patient in the hospital. Don't send home, because that patient will again become painful and stiff. And beyond 3 months, the risk of iatrogenic fracture increases. It's very important. While you are taking the patient in the OT, this is very important tip, hold the knee near the, just below the knee, not near the ankle, because that increases the risk of iatrogenic fracture. Be very gentle and do it under C-arm. Ensure your patella is mobile and don't force too much, because that you may cause a patellar or a supracondylar fracture. Now, after 3 months, you can do lysis of adhesions. Now, what is lysis of adhesions? You can take those patients who have not relented after manipulation or under anesthesia or after physiotherapy. Take these patients and you can take arthroscopic lysis, provided you have a good colleague who can release the PCL if it's a CR knee, and do a good arthroscopic lysis, remove the fibrous tissue, release the patellofemoral ligament, all of that. If your arthroscopic colleague or you're not confident, then you can do open arthrotomy. You can remove the scar tissue that goes from the cord mechanism down to the femur, clear both the gutters, remove the insert, use a thinner insert if possible, and do a lateral reticular release to increase the excursion of the quadriceps mechanism. Those are all very important steps and methodical that you have to do if you are choosing to do an open arthrotomy. Revision TKR one can do after 1 year, provided you identify malpositioned components, overstuffing, fixed flexion deformity, or certain other technical errors. And here we have to ensure you correct fixed flexion deformity and leave the knee little loose in flexion, so that keep it a little sloppy so that the patient gets that kind of range of motion. Now, whenever you are now treating surgically, we have done manipulation or lysis, but when we treat the patient surgically from 6 months to 1 year or after 1 year, we have to identify whether it's a CR knee or it's a PS knee. If it's a CR knee, you can use a thinner poly, recess the PCL completely, and use a deep dish poly and resurface the patella if it's not resurfaced. Now, there is slight catch here. Normally, when we do a CR knee, you put the tibia first and then the femur. But if you just have to change the poly, you can take the poly out, recess the PCL, and then you'll have to kind of push your deep dish, because it won't go easily, a deep dish. So recess the PCL completely, release the gutters, and push the deep dish poly, if thinner one size, if possible, you're doing for a stiff knee. Now, this is an extreme example of an unbalanced CR knee. You can see there it's an unbalanced CR knee. Patient can't get full extension, and the knee is subluxating anteriorly. Now, what that means is that PCL is not balanced and the knee is subluxating anteriorly. And at 1 year, this patient was fed up. The surgeon kept reducing it back and doing some manipulation and all that. But at 1.5 years, the patient was fed up and we had to revise. And I've never seen metallosis like this in 1.5 years. And the reason was that unbalanced PCL was pushing the poly in front. And in 1.5 years, the poly really eroded and there was metal on metal contact. And we had to revise this patient to semi-constrained kind of implant. Let's take this PS knee, and you can see that this PS knee is from 10 to 30, mediolaterally stable, but very stiff. I mean, I've never seen something like that, a PS knee, virtually 10 to 30, not having range of movement. Even after anesthesia, the surgeon had done everything, and we chose to revise for a PS knee. Now you can see this X-ray. If you see the lateral side, there is HO ossification there at 1 year. That means, you know, the surgery was a little crude, not as fine as it should be. The physiotherapist was trying something. This is not a drain. This is some kind of, jugglery that they do with bands and everything. You can see there is metal on metal. That means this patient in his fixed flexion deformity, you don't have any gap, very tight, stiff knee, a 10 to 40 degree range of motion, and we had to revise. So you can revise for a painful stiff knee. We choose mostly not to. We keep doing exercise. Exercise doesn't work. So you have to go methodical for these kind of patients. Few tips about resurfacing the patella. Whenever you're choosing to revise for a stiff knee, choose to resurface the patella and make it 2 to 4 millimeter thinner. Understuff the anterior compartment and do a complete lateral release to increase the excursion. Now, this is the take home from my side for preventing stiff and painful knee. First, to prevent stiff and painful knee, identify the at-risk patients for stiffness, and don't leave the operation table every day, every time without giving a 5 to 100. That's minimum. Ideal is 0 to 120, but even for post-traumatic cases, those having multiple surgeries, don't leave the table without getting 5 to 100. We have realized from our navigation data that whatever we give on the table, say we give 120, the patient will end up getting 110, 115. So whatever you get on the table, minus 10 is what patient gets in terms of flexion. So always keep the patient at least 110. Optimize patient factors like diabetes and smoking. Do not overstuff the joint in any plane, whether it's coronal, sagittal, or axial. Adequate pain control, rehab, minimum dependence on physiotherapists. Minimum. They do more harm than good, with all due respect. That was prevention. Take home for treatment. 6 weeks, supervised physiotherapy, not aggressive. Supervised. Manipulation under GA, provided you're sure that you will make the patient better and not worse. After 3 months, arthroscopic or open lysis of adhesions. After 1 year from index TKA, very carefully consider, rule out infection, and you can revise with the principles that we just described. Thank you very much.
Thank you, Anup. That was quite an exhaustive description of how to avoid getting a stiff knee. And God forbid if you
can't hear anybody. Hello?
Hello, can you hear me?
Nilen, are you muted?
No, I am not muted. Huh?
No, we can hear Nilen.
Were you able to hear? I'm not able to hear.
Anup, your talk was so good that you don't want to hear anybody. It was the gospel truth.
I'm not able to hear.
Okay, maybe there is something wrong with your laptop. Okay, we'll come back to that. But in the meantime, may I invite Dr. Jahangir Malakshmiwala from UK to tell us how not to get clicks and creaks from the extensor mechanism, and in case if you do get them, how to get away so that we have a satisfied and a happy patient. Jahangir.
Thank you very much, Nilen. Can you see the screen?
Yes, we
Yes,
can.
sir. Yeah, okay. So my remit is to talk on the patellofemoral issues, so where there is clicks and creaks. And it really, I think the plan of this to lead to mine after what you have introduced and Anup Jurani has said is excellent. The three issues for me to cover would be patella maltracking or dislocation, patella clunk, patella fracture, stroke, tendon disruption. And I'm very glad that Anup Jurani talked about decreased range of movement in patellofemoral issues, and that's a separate entity which he's covered, while I'll stick to the three things that I'm talking about, which is patella maltracking, patella clunk, patella fracture. And once again, none of us have discussed with each other what we were going to talk about, but all of us have been very clear that it's not just saying how we will tackle the problem, which all of us get referrals for, or what we get ourselves, but it's what we do to avoid it. So throughout, the sequence of every topic would be exactly what Anup Jurani and Nilay had said. I'll start with avoiding the problem, how to diagnose the problem, and how to solve the problem. And once again, I say this from my own experience of resurfacing and PCL substitute knees. I divide patellofemoral issues into two, which I have easier to do because my unhappy patients, which I'm going to talk about for patellofemoral, is very clear. They're dramatic, which is fracture, dislocation, or tendon ruptures. And then the sublime, which would be more difficult to tackle or to diagnose, but would be patella maltracking, patella clunk, and the unhappy knee where the patella was not resurfaced. So let's start with the first group, which is patella maltracking. The important point to remember in this is that the femur and the tibia are the tracks of the train, okay? So the main issue is the track, which is your femoral and tibial component. Your patella is the train. And like my colleague Paul Allen says, that most train crashes in the world happen because of track issues, okay? There's something in the track. So you've not laid your femur and tibia correctly. It's not the train's fault. So how much of manipulation you can do in the patella is less, unless, of course, there's a pre-existing patella issue like Anup Jurani says. So those are different. But generally, you have to ask yourself that your problem would be on your femur and tibia for your patella maltracking problems. So I do lateral release occasionally. I'm not saying you don't do it, but just ask yourself that each time you do it, it could be due to a degree of an issue on your femoral and tibial rotation. So therefore, I'll repeat a few things I said in my last seminars. Work on optimal flexion, work on getting a correct condylar loss if there is to diagnose that, and make sure your rotation on your femoral component is correct. So raise it off in a valgus knee if you have to. On your tibia, get your correct rotation any way you want. I use my posterolateral corner, and then I externally rotate my tibia. Why I've talked about tibial rotation and sizing is that sometimes, without you knowing, everyone's quest for avoiding patellofemoral problems is everyone says they lateralize their femur, and some people lateralize their tibia just because they want to get good patella tracking. I would say no, I like my femur central, and studies have shown that too much of posterolateral excursion of your tibial tray does cause problems on your patellofemoral tracking. All right, so correct sizing, absolutely no large inserts, large sizes of implants. And then once I got my rotation correct, I'm committed, okay? I'm committed and I concentrate on my patella. So a few points on my patella, which I do. So I start off by seeing how much my patella is. I know I've resurfaced now, but I would have started off seeing my original height of my patella. And most of the time is between 21 to 24. I'll talk about what to do in thin patella. So number two, I always use a jig. Whatever system you use, I use a jig. What are the mistakes you'll make on your patella resurfacing? One is that most jigs in the world, and that's the weakest link in knee systems, is patella jigs, is when you put your jigs on, open it up completely. So you have the largest space between the two. Put it in here and make sure you go all the way to the hilt. The mistake is people stop with their jig up till about here onwards. So you cut in a differential manner. And also this is lower and this is higher. So you cut at a slope. So you shouldn't be on a slope either in the medial lateral or the EP plane. How much to remove? Most of the time, the jigs tell you, most modern sticks will say 9, 8.5, etc. Now, no surgeon, at least I can't, maybe my colleagues can, but I can't cut to 0.5. So most of the time I do 9 millimeters, but I'll tell you when I don't do that. Next, where do I keep it? All the time, it'll be center on my mediolateral plane. I know people say medialize your patella. You don't have to. I like to be central rather than medial. And except if there are issues, and this is an important point that Anup Jurani made, if you pre-operatively determined a major patellofemoral issue, like a dislocated patella before you start, a sublux patella before you start, patella bha, that's a separate entity. But most of your knees, I go for a central position of my button, not superior inferior, not medial lateral. And most modern patella are oval and they are not round. So I don't know whether everybody does this, but I do this. So when I put my button on, I like to be 90 degrees to the long axis of my tendon. I don't want to be, for example, I don't want my button to be in this direction or in this direction. So 3 things I look for. I feel, and like the button's diameter is not important. It's more important to correct and get and recreate the patella height. So I don't want to be higher than I am. So what I do is when I drill my holes, I drill the holes with the largest diameter of my jig. Okay, so I put it on wherever the largest diameter is on bone, I drill my 3 holes. And then I use my trial buttons to put it on, and then I recreate my height. If I have to get a smaller button, which is lesser in thickness, so be it. So in other words, I prefer correct height to correct diameter. And that helps in recutting the patella, right? So I use my patella buttons to recreate height. And what I want is there's no lift off there. If I have to do a lateral raise, I initially just check by everting and I see where I am, and then I turn over and do a lateral raise. How to diagnose the problem? The history is classical. The patient says that they feel as if they're always worried about the knee, especially when they get up from a sitting position or trying to do stairs. So they are really worried, and they have a decreased range of movement, not because they can't move because they are stiff. It's just they are worried because the patella is unstable and it's going to fall off, and they get that apprehensive. Clinically, you may get an apprehensive test, but I feel compared to my virgin patients who I see with patellofemoral issues, this may not happen all the time because they're scarring. And like I said, a hesitancy to bend, which is not stiff. I take skyline views for every patient. If Nilen is there, he commented on that tilt because he does a subvastus approach. But I want to make a point of 2 things. One is a good skyline view does not rule out a patella maltracking problem, because a patella maltracking problem is a dynamic issue, not static. And the tilt, sometimes the patient with the tilt may get a fantastic clinical result. So I can't get correlated all the time, but I do a skyline like Nilen Shah correctly said. CT scan, yes, you need to know where we are with our rotational profile of a femur and tibia. My worry with CT is that we don't know what is normal. We don't know which knees were fantastic results with a degree of external rotation. But yes, it's part of your armamentarium to work up. We do that. So this is a skyline view, which we like to see. And then we see this with a tilt, which, like I said, you can look at it, but this should not be a reason if the patient is doing well to do something about. And then we have the true dislocation. Now, I feel in my practice, I do quite a fair distal femoral replacements for periprosthetic fractures because we get a very older population. And in these, I see it more commonly in my distal femoral replacements. Now, solving the problem, I really feel bracing will not help. Physio, I agree with Anup Jurani, cannot help for these patients. Surgery always. I do believe that we go in, we have an extensive lateral ease. I do a medial plication, and that's the proximal part of my quadriceps issue. I split my distal patellar tendon and medialize it. And in knee replacements, MPFL reconstruction, tuberosity transfers, I don't think they have a place. So I do the above 3. So just to point out what I do I split my patellar tendon, and the lateral part, which is here, I take underneath the medial part of the tendon and I raise a trap door there and I place it here. So that's what I meant by my distalization. Patella clunk, where that's now I've come to my second issue, which is patella clunk. Do you get patella clunk in PS knees? The answer is yes. And it's a victim of success. I've only seen it in my patients in those knees which flex greater than 120 to 125. Okay, you don't see them in stiff knees. So that's the first message. Should we be resurfacing in PS knees? Like I said, there are some knees, there's no evidence-based medicine, but there are some knees which don't do well with eversion. Patella, I feel the PFC sigma is one of them, and therefore I resurface them. It's very important, and this is where if you've done and all your patients are resurfaced, you'll be able to tease out a very important issue. You can tease out whether it is true patella clunk, which is treatable, or it's an unhappy, unsurfaced TKR patient. And enough studies have shown that if you have a patient who's coming to you, and I like to know that from my Indian colleagues who have a huge practices like you all do, as what do you think are the success rates of your patients when you resurface some of them when they come back to you, not your patients, but if you have to do them. My feelings, they don't do well, but the patella clunks do well. That's why I like to tease out the groups. How do I avoid my patella clunk issues? And that's important for anyone who's doing PS knees or resurfacing patella. First, I work on this area. So in the quadriceps tendon area, nibblers and sharp dissection to remove all tissue over that. I do not particularly think there's much work done on the fat pad. So I don't really work on the fat pad. The culprit is here. I use a saw, a small saw. See my patella there? I do a patelloplasty. I really bevel off this issue, and I believe this is important. So I do this third as well. And how do I now come to diagnosing a patella flunk? I want a patient who I only diagnose it after 12 months. So I don't rush in less than that. So 12 months have to pass. The patient has to tell me I am happy. So I need a patient who's smiling, who's not going to be angry with me. So he's a happy patient and saying, yeah, my pain relief is excellent on walking. So overall happy patient, but very clear that when he flexes, gets up on sitting position, stair climbing, he characteristically, without a doubt, heard a clunk and a creak. And that's when I will investigate. X-ray is not conclusive, CT is not needed. I do a CRP just to confirm I don't have an infection because I'm to intervene. There's always a place of whether you should do a arthroscopic versus open. For the last 10 years, I have myself and I take them on and I do it open. Okay, I know there's a place for arthroscopic excision of the scar tissue. It's done through a superior portal. I've tried it. I'm sure my arthroscopic surgeons can do it, but I prefer to do it now open. I do the same thing, a formal arthrotomy, overnight stay, and I rework on the issues. I'll finish with the last few slides with patella tendon fractures and disruptions. So worry in Indian knees, like we have discussed before, is there a worry of fracture? There may be, of course there is. I try to minimize my fracture risk by getting my height to 22 millimeters in females and 24 in males. Hence, I'm very careful of the amount I cut. Okay, so that's my goal. I want 22 millimeters in females, 24 in males. If the virgin patella, which I'm resurfacing, is 19, there is a literature evidence of a higher potential for fracture. In those, I do not remove my 9 millimeters. I remove just enough so I get it back to 20 or 24. Okay, so that's my avoidance tip for the fracture. It's very easy to diagnose. Okay, X-ray is easy, loss of extension. Just a point, because we do we got 20 years of experience of seeing PS knees with patella fractures. We sometimes very occasionally have seen pictures where the patients come to us at our yearly follow-ups. They can't really tell us they've had a fall, but an X-ray show a fragmentation of the patella within the sleeve. They may lag a few degrees of extension, but they're overall satisfactory. Those are the ones I don't revise, but that's very few and far in between. So generally we see this. So this is one, and we see this. So what do I see here? A high riding patella in a patient who's had a fall or said he's had a fall about 6 to 8 weeks after TKR, definite patella tendon disruption. But how do we treat these? These are difficult. If they've been resurfaced, then the button is all over the place in a fracture. K-wiring is difficult. I use a lot. And once again, I want to know whether my colleague surgeons used it. I only use a neo-ligament or patella tape. I've stopped using cross K-wires, figure of 8 K-wires. I use the patella tape. One of the tips is 2 things. Use a large drill to go through the tibial tuberosity, but keep in mind you have your patella, your tibia, and hence I use this. So this is your patella tape, which I use over. I expose enough that I can go and have a nice drill hole through my tibial tuberosity, which is there, but a large drill hole. And then I like to spread my this tendon mesh over over the entire extensor mechanism or the patella. And I'll end with that stiffness should not be confused with decreased range of mean due to instability from patellofemoral origin. Thank you very much.
Thank you, Jahangir, for a very nice and a descriptive slides of the different patellofemoral problems and your description of the track and the train. Now, to keep this webinar on track, we have Professor Malhotra, who is going to tell us that the most important cause of unhappy patient is the 10th cause. The 10th commandment.
Thanks.
So we have Professor Rajesh Malhotra talking to us on the 10th cause of unhappy patients.
Thanks, Nilen. And I never said it's the most important cause, but it is something which I would like you to and the viewers to be aware of. And
Sure.
so just a minute here. Okay. So good afternoon, and I'm going to talk about the 10th cause of the unhappy TKR, and I definitely don't want to say that this is the most important cause. I think you might have got a hint from the screen. Otherwise, let's go ahead. So it's a knee which looks good, feels bad. We all know that. And I'm going to talk about the incidence, etiology, diagnosis, prevention, and management of the 10th cause, or to say in words of my friend Jahangir, it is avoiding the 10th cause and then managing the 10th cause, and diagnosing and then solving. So this is a paper by Kelly Wins, a very seminal paper which is often quoted. I think there's hardly any paper on failure which doesn't talk about this. And this paper talks about the 9 causes of failure. And I was trying to count on Nilin's screen. So Nilin had shown only 8. So this, according to Kelly Wins, it's the infection, extension lag, stiffness, tibiofemoral instability, fracture, loose femoral or tibial component, patellar instability and malrotation, breakage of implants, and pain without any diagnosis. And the 10th cause, which I'm going to talk about, is the metal allergy or hypersensitivity. So it's so often it's such a sort of debatable topic that I thought that let me address the metal allergy or hypersensitivity in this talk. So when we talk about an ideal implant material, it must have optimal biocompatibility for prolonged periods of implantation, optimal stability and endurance, optimal fixation with the bone without inducing toxic reactions or activating the immune system. And we know that no material, excuse me, no material is ideal, as every material is a foreign body once inside us. In this paper in 2010, this was a review on metal allergy and about the exposures, penetration, genetics, prevalence, and clinical implications. And the authors said that the prevalence of metal allergy is as high as 3% to 17% in the general population, and majority of them are attributed to the occupational exposure. Now, these are the metals in orthopedics. This is the periodic table, and what you see in the green are the most important or most frequently used metals in the orthopedics. Then, what you see in the yellow, which is so the green is chromium, cobalt, iron, and nickel. The next common ones are titanium, vanadium, molybdenum, and aluminium. And these are the alloys. And then the manganese and zinc, and then the zirconium. Now, metallurgy in total knee replacement was first reported in 1966, which is what everybody keeps on quoting. The exact prevalence is not known, it's 0 to 5% as an estimate. But what is happening now is there is increasing reports of its incidence. So I don't think that we are actually getting an increased incidence, maybe a small proportion of pain without any obvious cause, as in Kelly's paper could have been that. It has been poorly understood, results are unpredictable, and it's highly debated. So let me just clarify a couple of terms. Hypersensitivity is response by immune system to an antigen. Allergy is the immune response, response that is immunoglobulin mediated. Now, the hypersensitivity or the adverse reaction or the allergy to the implant is actually a cell mediated immunity. So it's not an allergy, and so it's a cell mediated immunity mediated by T cells. So actually, it's a misuse of the term allergy. It would be either hypersensitivity or sensitivity to the metal. Now let's look at the pathomechanics. We all have these implants. We have the metal surface. And when it comes in contact with the oxygen and body fluids, it forms the metal oxide layer. Now, this metal oxide layer renders the metal inert. And how effectively it can do that depends on the dielectric constant of the metal oxide, which actually imparts a certain amount of insulation to the metal. Now, this dielectric constant of metal oxide is high for titanium, which means that it is most efficient at rendering the metal inert, whereas it is very low for cobalt, chromium, and nickel, which are therefore more susceptible to eliciting the sensitivity reaction. So that's why you have more of metallosis, more of hypersensitivity, more of these adverse reactions to metal debris in these metals rather than in titanium. And the common metals in alloys in the TKR, like we said earlier, are cobalt, chromium, and nickel. And the pathomechanism is that the metals themselves cannot cause any adverse reaction. The metal haptens have to be attached by the protein carriers to form an antigen, and this antigen is attached to the antigen presenting cells, which are the macrophages of the joint tissue, and that actually presents the antigen to the T cell, and that elicits a cell mediated immune response. Now, what are the clinical features? There can be discomfort, which can often be explained as pain. So that's an unhappy knee. So there could be pain, discomfort, reduced joint mobility, swelling, recurrent joint effusion, and loosening of the implants. And you can see none of these is really very pathognomonic or characteristic of the metal hypersensitivity. Now, the skin manifestations of hypersensitivity are rare because these skin manifestations are rare with total knee replacement or total hip replacement. They are mostly reported with osteosynthesis material like plates, nails, or screws. Now, there are only case reports in total knee. There are case reports of dermatitis, eczematous rashes, hair loss, local swelling, and erysipelas-like reaction, vasculitis in this seminal paper by Bircher in 2015. And this is that paper which led to patient presenting with systemic dermatitis and hair loss. Now, that is possibly one extreme. Now, what about the diagnosing the problem? So the common causes of morbidity must be ruled out first. So must rule out infection. And that's what I do too, even if I believe in metal hypersensitivity. rule out infection, reflex sympathetic dystrophy, instability, malrotation of components, and referred pain. Now, rule out other dermatological manifestation caused by other causes. For example, there's something called post-surgical dermatitis. Now, that has to be distinguished from the metal hypersensitivity, because in post-surgical dermatitis, the eczematous reactions occur along the suture line. And it's usually due to the surgical glue or tape or even to the metal in the staples. Diagnostic approaches, you must glean a complete history with regard to previous exposure to metals, occupational as well as recreational, previous adverse reactions to contact with metals, history of allergy to jewelry, particularly artificial jewelry, dental restorations, as you see in the slide here, the intravascular stents, metallic suture materials, permanent tattoos. And a complete clinical examination of the whole integument includes not only the skin, but the mucosa as well as the joints. Now, there are a lot of contentious issues around surrounding the appropriate testing for metal hypersensitivity, and there's a lack of consensus on the approach to the testing. The crucial questions are: is there a need to carry out screening prior to implantation as a routine? If screening is needed, what is the most effective test? What is the management plan for those who test positive? Should hypoallergenic alloys with which surgeons may be less familiar and they are definitely more expensive, should they be routinely used? And what about the management plan for patients with suspected metal hypersensitivity who have already had an implantation? So is there a need to carry out screening prior to implantation? So routine pre-implant screening or testing prior to surgery is not indicated. Neither scientific evidence nor legal agreements nor expert agreements are available to that effect, and majority of the tests are done as a part of the clinical research. This is a paper published in Journal of Arthroplasty, which looked at 161 total knee arthroplasties among patients, out of whom 56 were positive on the skin test, versus 105 MASH controls who were not tested at all, followed over a period of 5.3 years. And those with negative skin test or those with positive skin test, there was no difference in reoperation, revision, or complication rates between the two groups. So that paper suggested that there is absolutely no benefit to testing the skin test routinely. However, what if the patient gives a history of metal hypersensitivity? Now, in this paper, the patients reported metal allergy, and these patients who reported metal allergy, they had decreased functional outcomes after total joint arthroplasty. So this paper suggested that if a patient uh, is um, is reporting with the history of metal hypersensitivity, it may be beneficial to carry tests and or use an appropriate allergen-free implant to eliminate the patient worry. Now, the surgeons countries worldwide have their own protocol. In Denmark, there's no pre-surgery testing unless there's a history of metal reactions of magnitude sufficient to cause concern to the patient or to the doctor. In Sweden, they say such patients don't exist. They don't have metal allergy. And they definitely don't, sorry, I apologize. They said we never ever evaluate such patients. United Kingdom, they had say that the standard cobalt chromium United Kingdom is standard cobalt chromium and stainless steel devices must be implanted regardless of the patient's metal allergy status. In Germany, there's certain degree of consensus about using titanium alloys for any patient who reports the metal allergy on self-reporting, but they do not report any pre-implant testing. USA, there was a time when prior patch testing in patients was done, reporting a history, but then recently they do not recommend routine pre-implant testing, but in self-reporting evaluation is if it says on self-evaluation, it is suggested that you may do pre-implant testing, but it's not mandatory. So ultimately, it so transpires that it is up to the patient and surgeon to decide the best and the most appropriate device. Which test is preferred pre-implantation if required? So what we are trying to do here is to detect the delayed type hypersensitivity to metals. You can do a skin test, which is an in vivo patch test, or you can do a blood test, which is an in vitro test, which is a lymphocyte transformation test, LTT. Now, skin patch test is able to test the usually used most commonly for cobalt, chromium, and nickel. The metal chlorides are mixed with petroleum jelly and applied to the patient's skin in special hypoallergenic aluminum or plastic test chambers system for at least 48 hours. You remove them after 48 hours, take the first reading 20 to 30 minutes after removal. Second reading is at least another day. Some people say after 24 hours, the others say that even on day 3 or 4, because as late as fourth day, the tests have resulted in positivity. So that is to take care of the late positive reaction. And what you see on your right side is a different kind of reaction. So it could be a doubtful or a negative. There could be, so a negative is when you don't see anything. Doubtful is when there is non-palpable faint erythema. Then you have something which can occur because of irritants and not true hypersensitivity. But you can have a 1 plus, as we call, weak positive, with this erythema and discrete papules. You can have a strongly positive when you have the discrete vesicle in addition to the erythema and the papules. And then you can have a 3 plus where there are multiple vesicles coalesce to form a bulla or the ulceration. The advantages of skin patch tests are they are simple to perform, they are easily available, can be done on many patients at the same time. But then the disadvantages are they can give rise to false positive reaction. You saw that paper from Journal of Arthroplasty where 56 patch positive patients didn't have anything adverse at all. Skin exposure is actually not the same as constant exposure experience in a closed environment inside the joint. And then the skin patch test relies on Langerhans cells, which are the presenting cell, whereas we know now that the hypersensitivity to metal is because of the macrophages. So the lymphocyte transformation test, or LTT, measures the proliferative response of lymphocytes to antigens. And it is based on the premise that if the lymphocytes are already sensitized by allergens, they transformed into blasts and proliferate when they are again exposed to the antigen. And then you look at the stimulation index ratio, which is the ratio of lymphocyte proliferation after antigen challenge divided by lymphocyte proliferation in absence of antigen. And it's usually has to be more than 2. And the DNA replication is usually used as a measure of proliferation. So how much proliferation is occurring is as per the DNA replication. So this is the lymphocyte transformation test. You take 10 ml of blood from the patient, collect it in a heparinized vial, and then peripheral blood mononuclear cells are isolated by centrifugation. You can see the layer here on top of the gel layer. Then it is incubated with the antigen, which is a metal compound at a very low concentration, 0.01 to 0.1 millimole, and it is cultured for 5 to 6 days. And on day 6, the cells are washed and pulsed with radioactive DNA marker like radioactive hydrogen labeled thymidine overnight. Then proliferation is assessed as a ratio of incorporated radioactivity in stimulated versus non-stimulated cultures. And like I said, the stimulation index more than 2 is considered to be positive. Now, the disadvantages are that the LTT is not widely available for clinical use. It's expensive, it's time consuming, may produce false negative results if the test is not transported and safety and not processed in a timely manner due to rapid T cell decay, is not standardized, and there's a great degree of inter-laboratory variability. So what about a patient who already has a knee implanted and you want to test him for hypersensitivity? And that should be suspected only in patients who experience persistent symptoms after TK in the face of normal lab workup and all other causes have been ruled out. Major diagnostic criteria to establish the metal hypersensitivity are: 1, the chronic dermatitis beginning weeks to months after metallic implantation. The second is a positive patch test reaction to a metal used in the implant, which should ideally be followed by LTT and consideration of revision surgery if they are highly corroborative in a symptomatic patient. And the third one is most important, that there's a complete recovery after removal of the offending implant. And this is what the histology picture looks like. This is definitely an adjunct to diagnosis in the post-implantation hypersensitivity. You can do it on the tissue collected during revision surgery, or if in doubt, you can take an interim synovial biopsy before going full throttle for revision. And what it shows is the fibrocollagenous soft tissue proliferation, the foreign body giant cells here, and the mild chronic inflammation of all these cells which you see here. So my approach is pre-surgery. We don't do routine pre-surgery testing. We do skin testing for patients reporting with history of metal reaction, particularly to artificial jewelry, hypoallergenic primary implants after discussing with the patients who test positive. Post-implantation, we again start with skin test for all suspected cases after ruling out other causes of symptoms. The lymphocyte transformation test is done if the skin test is positive, or even if it is negative and we think that there's a strong suspicion. We do a synovial biopsy if it is associated with implant failure, and we use hypoallergenic revision implants after discussing with the patient. So this is a very big challenge, and I'll talk more about it. Now, we said that the LTT is not standardized. So we standardized in our hospital the lymphocyte transformation test by doing it initially on 3 groups of patients. The first group is patient to be tested who have had a total knee replacement and this who are symptomatic, which are so to call suspects. Then there are the healthy patients with well-functioning TK who apparently have no hypersensitivity to metal. And the third group was the healthy patients without total knee or without any other kind of implants in vivo inside their body. We collected 10 ml of each blood sample in an heparinized vial from all of them, isolated the peripheral blood mononuclear cells and divided into 3 vials each, incubated with antigens. Now remember, the antigens have to be in a very small concentration, enough to elicit a hypersensitivity reaction and low enough as not to cause the toxicity to the cell and the death of the cell. So the cobalt, chromium, and nickel compounds were at a concentration of 50 microgram per ml. Then the fourth sample was when there was no metal inside, cultured for 5 to 6 days. So it avoided the use of a radio-labeled thymidine. And what it did was, again, the 6th day, the cells were washed, stained with fluorescently conjugated antibodies, again, T cell surface markers CD4 and CD8. We could have done it on any of the cells, but we wanted to see whether there's a difference between these two distinct population of lymphocytes when it comes to the proliferation. And then instead of the radio-labeled thymidine, what we did was we did the intranuclear staining with an antibody against the Ki67 protein. Now, Ki67 protein is found in the nucleus and is associated with the proliferation of cell division and is a marker for cell proliferation. And the stimulation index was determined as a ratio of Ki67 positive metal stimulated cells relative to unstimulated controls expressed on a histogram. And this is a classical histogram. So you see, this is the control. The blank boxes are the controls, and these are the patients. And you can see this is the reaction to nickel, to cobalt, and chromium. And this is in the cell population, which are CD8 positive cells. And this is the same patient, the CD4 positive cells, again, the expression of Ki67. And you can see it is definitely more than twice. And you see this patient has shown that it is hypersensitive to cobalt and not to chromium or the nickel. Now, this is a 56-year-old female who presented 4 months after injury with pain, swelling, and deformity. And there was a catastrophic failure. And what else other than infection would we suspect? There was no skin manifestation. And this was discontinued, unabated, 6 months post-op, progressive deformity, lab workup was normal, aspiration and culture ruled out infection. The skin patch test was equivocal. So we proceeded to the LTT because of the strong suspicion, because we were not able to establish infection in this. And this is how her T cell proliferation assay was before revision surgery. So she obviously elicited a lot of proliferation of CD4 and CD8 cells as seen by excessive expression of Ki67 in response to cobalt. And you can see in this particular group, there was a patient who was like healthy control without TKA. And you can see that there was no difference between a patient who had no sort of apparent hypersensitivity to implant. It was same as somebody who didn't have any implant inside his body. And this was actually pretty painful to get this. There's apparently only one set in the world or two sets in the world, and we had to wait for a few months before we could import it from Europe. We did the revision surgery with hypoallergenic implants. We took the intraoperative samples to rule out infection. This was the intraoperative histopathology, classical of the metal allergy, and no evidence of infection here. This was at 3 months. We repeated the Ki67 expression in the same patient, and you can see as early as within 3 months of the surgery, everything had come back to normal like a control. And this is 5 years follow-up, and she hasn't failed since, and she's asymptomatic. She's still waiting for a knee replacement on the right side, but has remained happy ever since. A word about cement hypersensitivity. Now, there is something called PMMA hypersensitivity, which actually occurs to a component which is benzoyl peroxide in the bone cement. These authors said that they were referred these 5 patients who had later on exhibited the contact sensitization with benzoyl peroxide, and that's even more uncommon cause. But then if that happens, you have no option other than to go for uncemented prosthesis or the arthrodesis. Now, quickly about my journey in primary knees with history of metal hypersensitivity is not relevant because we are talking about the unhappy knee, but just to give an example, 60-year-old female gave history of hypersensitivity to artificial jewelry. So implanted with oxenium knee. This 61-year-old female history of the allergy to artificial jewelry, implanted with the AS or the allergy solution gold knee by B. Braun. And 57-year-old female again implanted, needed a partial knee, was implanted with oxenium UKA by Smith and Nephew. And these were the intraoperative pictures. So I mean, we know oxenium is something which does not cause any metal hypersensitivity. That's one of the options. This is a 72-year-old female who's doctor by profession, and she was allergic, and she insisted that she wanted only hypoallergenic kind of implant. And we do a navigated TKR in all patients or UKR in all patients above 70. So we chose an implant which can be put in with using navigation. So this was the gold uni, the allergy solution. About the unhappy knee, we have had suspicion in 31 patients, out of whom the 7 were positive on the skin test, but then 4 who were LTT positive were the only ones we treated as really the metal allergy, metal hypersensitivity. We have revised 3, 2 are available for follow-up. 1 is lost to follow-up, not reporting, not contactable, and 1 is waiting for revision. This is another patient, 62-year-old female, presented to us 1 year after surgery. We ruled out everything. The skin patch test was positive. LTT tested positive for chromium and nickel. And then again, this was revised by the allergy solution. Now, the previous patient which I showed you was not allergic to nickel. This patient was allergic to nickel as well. So we wanted to avoid the titanium, because even titanium has got traces of nickel, and over a large period of time, the nickel may leach out of titanium and may collect around the periprosthetic tissue. We didn't want to take that chance, so everything had to be the gold, even including the stem and the augments, because many companies will still give you these stems which are cobalt chromium, and it defeats the purpose. And even if they are titanium, then you are worried about the nickel which can leach out. And there's a 3-year follow-up of the same patient. So my algorithm is ask the patient if he or she is allergic to any metal or artificial jewelry. If they are not, go ahead with the conventional implant. If yes, we do a skin patch test. If it is negative, you can discuss with the patient and give them the option. And if they don't want it, just go ahead. At least you have taken on board and are not liable medico-legally. If they are positive, they are subjected to T-cell proliferative assay. If it is negative, again, go back to discussing it with the patient, giving them an option. But then if they are positive, we recommend only analergic implants. To summarize, metal allergy, though rare, is an underestimated cause for an unhappy knee. Rule out all other possible causes to give rise to those symptoms, because the other causes are far, far more common than metal hypersensitivity. prior history to all significant metal hypersensitivity. Skin testing may be inconclusive. LDT must be done and it must be done immediately after taking the sample, otherwise it can be false negative. Final diagnosis to made by collecting all findings, including amelioration of symptoms after revision, and discuss with your patient regarding implant choice. And this is the chapter in my book on revision knee arthroplasty on allergy in total knee arthroplasty. Thank you very much for your attention.
Professor Malhotra, thank you very much. I think your cause is quite important. And although in my practice, I have sometimes considered the diagnosis, I have not yet seen a documented case, and I have not revised anybody saying that this was documented hypersensitivity. We do see a lot of patients with some kind of skin manifestations around the scar, but generally I label them neurodermatitis, probably due to the damage to the infrapatellar branch of the saphenous nerve. Maybe the other faculty members also could give their opinion, but I take your point that metal allergy can definitely be a cause. And Jahangir is raising his fingers, and UK government is saying that this doesn't exist. So what has been your experience, Jahangir?
Yeah, thank you, Professor, for raising it. And it is important because it really is a medical legal issue, right? So we have to be clear. So the way I do it and the way we do it in England is for every patient I see, I document in my notes that I've asked the question. So I think that's important to do. So if you ask a question, I document it. If the patient says no, then let's assume that after that, the patient has an issue of a unexplained pain or a dermatitis. At least you ask that question and clear on what's done, right? So that we are clear on. Let's say the patient says yes, then the issue is what to do. So we are very clear. Our guidelines are that I tell the patient I will not use skin clips because skin clips are going to be a dermatological problem to you. But I tell them very clearly that what happens inside your body is not going to be manifested as what happens to your jewelry problem. So I tell them that. I agree with Professor that, yeah, there is issue with your testing that it is there, but we have clear, I mean, we are supported that I can use my conventional implants. So I say that to the patient and I carry on with my normal implants. Okay, I don't change. Let's assume what happens then if the patient comes back to you who had said no, right, but now has a problem. I've had two, and both, I agree, have been a headache to me in how to manage them. Because, yeah, they are taking you forward to cause a problem, saying that you did something which you should not have. And those patients did have dermatological issues, but not only in the scarnulin. This patient had issues all over the body. Now, I can't say it is due to the knee at all, and I stuck to my premise that it's nothing to do with my knee. But unfortunately, the patient will go to a dermatologist, and the dermatologist will do the testing and ask for your letter saying what implant did you use, and you'll get a letter back saying that it's positive. And then handling that patient becomes difficult. And the issue, even in UK, is that really revision implants to get truly hypoallergy implants is an issue. So we are clear that we can use convention. And I think for normal practice, let's accept we document, and then I use normal implants. And that's the algorithm we use. But I take your point, Professor. We need to be very clear in countries as to what we are doing. It's a minefield of medical legal issue.
Jahangir, just to ask you one question here, that supposing the patient says, yes, I'm sensitive to metal. You say that I won't use the clips, but the inside mostly shouldn't give you a problem. But yeah, if he says, if it may give me a problem, what is the solution?
The solution to me is I'll say that, look, the best result for you is I do a knee, which I've done for thousands of my patients, which got the best track record, which you need. And that's what I'm going to do for you. And I've not had a patient who's not agreed to it, but I got the backing of my colleagues and the body that I'm not doing something completely grossly opposite. But if you don't have that backing, then I would have been worried, right? So for you, I would say you probably cannot take that. I don't know, I'll leave it to you all, but at least I've got my support.
I mean, we have freely available components, non-metal. So to avoid that problem, I can see Professor Malhotra's point quite clearly. And
Very much, very much.
yeah. Anup, do you want to add anything? Yeah.
Yeah, I think as a routine, I use oxenium for all my patients.
Okay, so that's the other side.
So that's rather than you can do your with the history patch test, and if somebody is sensitive to cobalt, then I would do oxenium on all poly, and that is what I do for a lot of many patients otherwise as well. So as a
Correct.
premise, I presume that some of the women are in a subtle manner allergic to metal, and they may, if not have overt failure, they may still have skin problems. So better to use less allergic implants, as a prevention.
Right, right. Anupam, I believe you have some questions.
Yes, sir. I would like to.
Sorry,
Can I say
Professor
something?
wants to say, please, yeah.
Yeah, just to reiterate some important point and not necessarily what I'm saying. One is that I totally agree with your point that there is something called neurodermatitis, which is a fact. Our dermatologists, they diagnose that very often to the patients of ours who get that reaction, and it's exactly because of the division of the saphenous nerve. So that is one point to be kept in mind. In fact, I did try to tell that anything which is around the skin in front of the knee is not metal allergy and can be because of other things, and I tried to show a picture as well. And one of the reasons I did mention, I agree with Dr. Jahangir that the clips can cause that, because if you're allergic to metal, they can give rise to those kind of things. But there was this paper by Bircher which said that the patient got alopecia on the scalp. Now that's a very unusual thing, but then it is reported. There are reports of rash umbilicus because of a total hip replacement. So we are not talking about a local rash, which is actually not a very prominent or common feature, because I don't want this wrong message to go. In fact, all the skin lesions we see around the knee after knee replacement is very, very unlikely to be the metal allergy. That point must be understood, because there are other causes, including the neurodermatitis. Next time I'll put a picture in this talk of neurodermatitis. And I totally agree with you. Thanks for making that point. That's what I wanted to say.
Right. And Anupam, before I give it to you, this is मेरी कमीज यानी तेरी कमीज मेरी कमीज से सफेद क्यों? I don't know whether the faculty has had these questions, and you have the patient who is doing well otherwise, but seems to complain that somebody else is doing better. Jahangir, do you have these patients?
Probably because to a certain degree, patients, if you're asking for patient-to-patient comparison, probably more than patient-to-surgeon comparison. What I mean is that the patients will not really be shopping around to go to someone else if they're not truly happy. They'll come back to you only. And that's the advantage we have in England. So they will not go to another surgeon to get that opinion as to when they're happy. Okay, so that will be, they'll stay with me. We are patient-to-patient comparison. We have a knee class. So all of them come back and see each other for the first 6 weeks. And in that, more than a comparison, the UK patients probably take it as a competitiveness, I think. So I really don't see someone, they always say that this one is doing better, but I tell them that the reason for that is what each one was before we operated, that's the difference. Yeah, so
right.
yeah.
Right.
So we probably see it everywhere, we'll see that. It's not that you won't.
Right. Dr. Jurani, do you want to say anything to this? Because I see these comparisons all the time.
Yeah, so I just give them a couple of similes that tell them that even two twin brothers are not the same. So how can two knees, your own left and right knee, be the same? They'll be all right in about 6 months' time. Right. And every patient is different in terms of, the pain receptors and so many different things. So I think it needs a little bit counseling. That's it.
Right.
Perfect.
Okay, Anupam, do you want to ask the questions that you had in mind?
Yes, sir. I have a series of questions with the faculties, and this is more of a practical approach because we have gone through a lot of academic thing right now. But I think this will benefit the listeners. That a quick question from all the faculties. The first question is, what percentage of patients do you see, like out of 100 patients, how many patients would you say in your clinic come as unhappy? you will quote them as unhappy. So I'll just ask the faculties to go through it as a quick question. Dr. Nilan Shah, sir?
I think, as I said in my talk, maybe 5%, 5 to 10% max.
Okay.
But
Professor?
there is no
So-
documented foolproof data on this.
Yeah, that's what I'm saying. What do you think? You will say that this is an unhappy patient. That's what I want to know with all the faculties. Just a epidemiological survey kind of a thing. Professor, what would you say?
So I would agree with Nilan. It's not more than that. It's actually, I said it in my previous talk also, the last time, that our rates of dissatisfaction are far lower than the Western world, mainly because our patients don't do all those things which their patients say they are unhappy because they can't do gardening, because they can't do skiing, because they can't do mountain climbing and those sorts of things. I think by and large, if you ask me among my patients, if they are unhappy, it would most commonly because of some crepitus in the knee, which is actually very common. That would be one of the things. And the second thing is something like a complex regional pain syndrome, kind of hyperesthesia and temperature changes, and some which all happens because of the division of the infrapatellar branch of saphenous nerve. Those are the things which keep on troubling. But by and large, I keep on telling them that if you have symptom after 1 year, then I'll really be concerned about this. And I think our dissatisfaction rate after 1 year are pretty low.
Sorry, how much, sir?
Very low, very low.
Like, can you just give a rough estimate of out of 100?
Yeah, it's less than 5%, just like Nilan said. I don't think, you see, because you see, if you have, we are talking about, and I presume the subset which myself and Nilan are talking about are those who are perfectly well done. And that point is being missed here, that we are talking about all the technical causes and all. There is a subset which is unhappy in spite of a perfect knee surgery, and this percentage of less than 5% for us and higher for United States or other Western worlds is because I'm talking about something where there's no technical fault, everything is perfect. That is, I'm talking the patient where surgeon is happy, patient is unhappy. And that's where this RSD or the crepitus or little bit of, or not getting the terminal 15-20 degree of movement, or possibly like it was said, maybe some dissatisfaction. Incidentally, let me tell you, Nilan, if you permit me, we have done a thesis on the psychological factors which you mentioned right in the beginning. And in addition to what you told, and I was very happy to know that you talked about the parameters, we also, pain catastrophizing was assessed by my postgraduate. We also looked at kinesophobia, and we used the Tampa score of kinesophobia. We also looked at the HAD score, the hospital anxiety and depression scores. And we tried to associate the outcome and dissatisfaction with the psychological factors. And in fact, there is no previous study of the cutoff given for these scores for Indian patients. They are all Westerns. And we found that we had higher rate. So if it is 30 in the West, it's 35 cutoff for Indian patients. So in general, the psychological factors play a lesser role, as we could document in this thesis, as compared to the Western population. We have submitted it for publication.
Right. It will be very interesting.
Dr. Juran, thank you, sir. Dr. Jurani, sir, what would you say?
Yeah, so we maintain a prospective database and we keep calling our patients at 6 weeks, 3 months, 6 months, 1 year, and 2 year, 5 and 10 years, like that. So we take the patient reported outcome measures, especially KOOS, high flexion knee score, and WOMAC. And we have seen that the improvement in these three scores happens up to 1 year, right? So 1 year is the time when the patient could have a forgotten knee. And the aim is to find out how many have a forgotten knee. About 80% patients of our patients have a forgotten knee post 1 year. And unhappy truly who say we are dissatisfied and the WOMAC is below a certain index are about 3 to 4%. But post 1 year.
Okay, sir. Dr. Mahalakshmi, sir.
Yeah, thank you. First, I just want to clarify what Professor Nilan and Anup Jurani said. We are talking about unhappy knees as only those knees where we've not technically found an issue. Okay, so let's be clear on that. And in those knees, I would really say it's less than 5%. But, and it's a very important but, that I have the advantage in UK of extensive counseling. So one is you have to counsel, and that's why Nilane's talk I'm going to give to everyone in the UK, to my fellows and registrars, that's very important. Counseling for those patients who are not going to do well is something which is paramount, and I can hold them off for about 1 year. So I can go on saying, no, you're not ready, no, you're not ready, till 1 year on. Very unlikely they'll say they're unhappy after that, after I do it. So that's one. Secondly is that what Professor said is right. If your practice in anywhere in the world is biased towards taking on young people who are into sports and saying, oh, I'll get you back to your skiing, your tennis, that's where you're going to make a mistake, all right? If your bulk of your practice is correct Venn diagram, what Nilen shows, you're getting it all right, that unhappy group will be less. So my patients, I live in an area just outside London, elderly population, I operate on every young patient as well, but bulk would be the correct indication, so therefore you get it less. And I think what Anup Jurani said is absolutely paramount. You have to have follow-up. So mine is 6 weeks. If they're all right, then 6 months, then 1 year, and for life. Okay, and for life is that I just follow them up, so you get that picture. And data collection, and we do in our private hospital, we have friends and family tests, data collection, and my private hospital where I work, we got the second highest outcome for hip outcomes for hips in the UK, and third in the top 3 for knees. So we are very particular about outcome measures for patient satisfaction.
Wonderful.
Thank you, sir. Now, the other question I would ask all the faculty is, how would you approach a patient who's unhappy and has come to your clinic? Just, although you have already told this thing, but I would like to again go through it. How would you approach a patient as a practical approach into your clinic, try to separate it from the other patients or whatever? How do you go through it? Dr. Nilesh, sir?
Yeah, Anupam, if I may answer this, but before that, I just want to make one comment about the previous question that you had. Like sometimes when you go and visit certain conferences, especially in the United States, and you see the patients who are getting operated, the extent of arthritis at times is so minor that you would wonder whether, knee replacement is the best thing that's happening to them. And sometimes in our practice, we would hesitate even to give an intra-articular injection to these patients who are getting operated. So we are probably talking about 2 diverse sets of populations. Yeah. Here, the patients that we see, we don't have to hunt for arthritis. It is quite glaring at us. Whereas, in certain other countries, the degree of arthritis, at least in some cases that I have seen, is I would not say imaginary, but just there. Now, coming to this question about how to handle the unhappy patient. I think it is going to take all your skills, not just as a person, but as a clinician and as a human being, as to how to tackle this patient. So obviously, you have to be first rate in your knowledge. So you have to assess the patient well. So get new X-rays done, clinically examine the patient. If required, get a CT scan done and reassure yourself as well as the patient that there is nothing going wrong. If required, aspirate the knee. If on all these things you have ruled out any major problem, plus he has a reasonably good range of movement and clinically the knee feels stable, you know that you are on some kind of a wicket where if you just stick on, the patient is likely to do well. But you have to be able to convince the patient to hold his horses and not jump the gun. You have to explain to him that just because he is unhappy, that doesn't mean that he cannot be made more unhappy. Especially if you jump the gun and do some surgery, the likelihood of success is low and the likelihood of further complications is higher. Obviously, you have to evaluate him such as if somebody else has operated him. Listen to the patient such that somebody else has operated him. Take out the emotional component altogether. Just listening to the patient clearly for an extended period of time, I would say around 20 to 30 minutes, is quite therapeutic. Because the patient sometimes just wants somebody to listen to them, which they at times don't find at home, or they don't find a suitable medical person. So being a good listener first and then giving your opinion, I think works wonders. I will allow the other faculty members to give their views because this is a very, very important question.
Professor, your comments, please.
So I agree. I think, Milan, you have just been echoing my sentiments today. I also tell them, my way of telling them that I'm not operating is, I tell them if they insist about surgery and I'm not convinced, I say there's no disease which cannot be made worse by surgery. So that's the thing. So you don't think that you are the worst that you can be. Practically the same thing which you said. And I'm reminded of the very interesting episode by Bob Bone. He said that his secretary, she asked if somebody else has been operated, the patient has been operated with somebody else and wants to review with him for an unhappy knee. The first thing the secretary will do is ask him, when were you operated? And if it was less than 1 year back, she'll just politely turn him down and say, the doctor will see you once it has been 1 year and you still have problem, come back. So he says, I don't see anybody else's patient. So I do the same thing. So I don't go out on witch hunting. If my colleague has done and there's nothing wrong on examination, I say, okay, then you don't need to do anything till 1 year. Just go back. The same thing which I'll tell to my patient. And I think it's very important that the time period, and of course we all know about ruling out infection, looking for instability, looking for the range of motion, capitals, patellofemoral problems. But then if everything is fine and it has not been 1 year, I would just frankly tell them that you can. And I think it's more important to tell them before surgery. Very often the patients ask you, how long will I take to recover? And my answer is, it depends on what you mean by recovery. If you mean walking, getting up and walking, it will be on day one. If you think, if your recovery means when will you be able to climb stairs, it will be on day three. If you mean that when you will have, you can go to work, it depends on you. But even so, 90% of the recovery will take place in 6 weeks, but then it will plateau. Then it will slowly go on till 1 year, and till 1 year you may have some problem, little bit this that, difficult in getting up from chair, little bit of problem on the stairs, but I'll be concerned if you have any problem at all after 1 year. That's how I tell them.
Thank you, sir. Dr. Jurani, sir, would you like to add comments on this?
Yeah, so I think the most important to me is to rule out infection, because that's one cause that's underestimated. A lot of covert infection is there in these unhappy patients. So be very meticulous in your infection protocol and rule out infection through, that's a separate discussion. That's one thing. And at 6 weeks, if the patient is unhappy, do your skygrams and rule out any coronal, sagittal, or axial malalignment, component malposition. Any identifiable cause which you can correct or which needs a revision immediately or later on. Once you got these skygrams, right, and there is no infection, then the patient needs counseling, and something that we discussed, maybe manipulation at 6 weeks or lysis at 6 months, depending. You should be sure that next intervention is going to benefit the patient.
Thank you. Dr. Mahalakshmi, sir, would you add something?
Thank you. I mean, everyone has said exactly what I would do, but what I would do is, on 2 occasions, I tell every patient, the first time when I see the patient in the clinic, I say very clearly, your night pain is going to be very bad at night following your knee replacement. All right. So I tell them very clearly, I tell the husband or the wife that he will be cribbing to you or for the first 6 weeks. I tell them again that point, that I'm telling you your first 6 weeks at night will be very painful. I tell them when I see them, the next day after I operate, so in the hospital. I clearly tell them, like Professor has said, that up to 6 weeks to 3 months is the recovery, and knees improve up to 12 to 18 months. So that is that carrot. Okay, the carrot is knees improve up to 12 to 18 months. I say that very clearly. Between the 6 weeks and the 3 months, I do CRP to rule out infection as really, and if it's plumb normal, very unlikely, but let's not go into ruling out infection. But I agree with Anup Jirani, it's important. I do all my x-rays, and that x-ray collection would include hip x-rays and MRI scan of the back, because the perceivement, like Nilen Shah said, the perceivement that you're doing a huge amount for an unhappy patient is important. So I do it, or I just do an x-ray hip and I do an MRI scan, because they'll have some degree of radiating pain. And at about 4 months, I send them to my colleague who I trust, who will say, I know the colleague will say the same thing. Look, there's nothing can be done. And then I carry on seeing my patient on a regular basis. That patient's name is in my book, and they can come and see me more often than not. And that's how I control my unhappy patient.
Thank you. Last question in this series is I would like to ask questions, faculties. Like Dr. Nilan Shah sir pointed out, the unhappy patient finds you. How would you see that this patient is going to be unhappy post surgery and just will try to not do the surgery for him and convince him to defer from surgery? How would you find out that this patient is going to be unhappy despite all your efforts and everything going right? No organic causes. Dr. Nilan Shah sir.
So, I mean, we are not trained psychologists or psychiatrists, but being in clinical practice, we tend to pick up patients who are complaining of pain for which there doesn't seem to be any organic cause. As I said, somebody who is catastrophizing or somebody who's complaining of pain all over, or you know, you tend to pick up these patients. Plus, obviously, somebody who is having a lot of radicular pains, these and knee arthritis. If you do their knee first, you are not likely to make them very, very happy. So you have to be a good clinician to find out which patients will do well. And for that, what I showed, that the diagnosis, the clinical findings in the history, and the imaging, when all three are coming together for bone to bone arthritis, these are the kind of patients that you want to pick up. Due to the popularity of knee replacements, we are all seeing a lot of patients who are willing to get operated. But we have to be kind of the check post to allow only the right indicated patients in. Otherwise, knee replacements will soon start getting a bad name. So this
Professor.
is how I check out.
Thank you, sir. Professor, your comments, please.
So, if the symptoms are out of proportion to the X-ray findings and the clinical examination, it's a patient to beware of, because a patient who's actually complaining repeatedly, they are the patients who will complain after the surgery also. So I agree, we are not trained psychologists, but those are the patients. And interestingly, I'll again say there that in our study, the patients who came out worst in these parameters were widows. Single widows who were living alone and who were widows did the worst in these outcomes. But in Germany, they say if it's a red-haired teacher, she's much more likely to sue you. In many other cases, then it's the presence of a paramedical worker within the family or the patients who often come to you with these kinds of complaints. And one of my mentors in Australia, David Morgan, who incidentally was an expert on many medical legal cases, also used to say that if a person wears sunglasses indoors, beware of that person. So you pick up your own cues.
Dr. Zirani, sir.
I look at the family and the attendants very carefully. So if the patient has come at the right time, let's say minimal deformity, maybe with a stick, with a son or daughter, you can see that they are caring, they have a family, I think they will recover well and less likely to be unhappy. Patients who are neglected on a wheelchair, 5 diseases, neglected diabetes, a family, fighting amongst themselves, one son choosing to take care, one son not, and so on. That kind of patient and family is something that I would be wary of. So I look at the attendants, the family situation very carefully.
Okay. Thank you. Dr. Mahalakshmi, sir, please.
Yeah, I think I can't add any more to what my colleagues have said because they all have huge practices and exactly what we see anywhere in the world.
Yes, sir.
Just a point on my colleagues for what is your view on high BMI patients in India? In the UK, we have obesity patients. My feeling is once you operate on them and they do well, they are very grateful patients. Okay? So they are not the ones who complain, the true obese patients. Is that the view of my colleagues? That's one question. And the second question is, in the UK, there's a financial drive, not in the private, but yes, to certain insurance companies as well. But NHS, you are not allowed to operate on someone who has a BMI over X amount unless you prove 10% of loss of body weight. Now, initially as surgeons, for the ones which may be done for financial reasons or cost cutting, it's not right. But if it's truly done for someone who is obese, that's, approaching 40 BMI, why is there a place, therefore, of making those patients earn their, to a certain degree, become a little healthier by 10% loss of body weight? That's what we do in the UK. And is there a place of doing it in your type of pure private work or professors, big, extensive tertiary referral center work? Is that a place?
Yes, there is a place, and we do advise them to lose weight. We do have a very active bariatric unit here. We do send them for consultation there also, if for nothing else, then only to emphasize and reiterate to them that it is so closely linked. And I also even tell them that if we all know that losing 10% is the magical figure, and I tell the patients, myself also, that you don't have to come back to your ideal weight for height. If you get 10% reduction, you get all benefits of weight reduction. And there is a chance, and I tell them that if you lose this weight, not only it will make my job easier, but there's a good chance that you might be able to postpone it for a few years or not need it as urgently as you feel it now. So we do that. And that's a very important point, I'm sure.
Let Anup answer.
Yeah, so it's paradoxical that most of these patients who actually need bariatric surgery are 60 plus, and most bariatric surgeons don't operate on patients 60 plus with multiple comorbidities. So while we may send them more often than not, the answer is that we will not operate. And most of these patients can't reduce weight by whatever. Even that 10% is so difficult, so big a goal. So I would actually go and operate. I would be more worried on the hip side than the knee, because it's the local problem also increases in terms of the height of the fat, but not at the knee. So I would go ahead and operate, and most of these patients lose weight after the surgery when they start walking. The trick is not to leave these patients loose or in hyperextension. Give them 4 or 5 degrees of flexion. They are huge, and when they lose weight, they walk, they don't go into recurvatum. So I think those are certain things you do, but I'm not very fussy about not doing the operation for them if they have bone-on-bone severe arthritis.
Sure.
In my experience also, it's the young patient with arthritis. I would be a little bit hesitant to operate, and I would at least send them for a bariatric consultation. But older, above 65, I would take them on, but I would counsel them that the rate of infection is a little bit higher in morbidly obese patients, so that they are aware as to what they are getting into. So God forbid, if something does happen, at least they know that the rate is a little higher.
Thank you.
I think so that's all question from my side. If the faculties want to add something, or Dr. Nilesh, sir.
I think we should all, for the younger house, for the people who are just starting, we should give our parting comments, 2-3 lines as regarding the surgical technique, how to avoid getting unhappy knee. Few points, but really those caveats. A 1 minute part-time shot.
If I may add, what I have understood is unhappy knee is when the surgeon is happy but the patient is unhappy, right? And sometimes when the unhappy knee is when the surgeon is also, we can divide it into 2 groups, when the surgeon is also unhappy and the patient is also unhappy. So if the surgeon is unhappy, it is because of some organic causes. And if the surgeon is happy but the patient is unhappy, then the surgeon has to convince the patient that it's not because of any organic causes and needs to get counseling, and it will get all right. If I'm right, and please the faculty is to comment. Dr. Nilesh, sir.
I think essentially what you are saying is true. That the surgeon will be unhappy when in his heart of hearts he knows that there is something that he should have done which hasn't happened. So ideally, we should not be landing into that situation that you don't want to leave a knee, too tight or too lax, or patella maltracking, or flexion extension imbalance. You don't want to get into these things. If the patient is unhappy, then it is generally a matter of time, but there may be other things also that we have discussed. Now, I think for lack of time, now it's almost 2 hours have gone by, and we had this meeting for 2 hours. So we will start off with Anup Jurani's suggestion and give our parting comments. So I would say that if you are starting off, for a junior surgeon, what is most important is do not leave the knee tight. My second thing will be make sure that the knee is extending fully on table. It is very often that you find that the knee is extending, but it may be around 5 degrees of flexion deformity that you leave the patient. So I personally would like my knee to just hyperextend around 4 to 5 degrees on table so that I know I'm not leaving a flexion deformity and I'm okay with 2 to 3 millimeters of laxity also, but I don't want to leave the knee tight because I believe that's a recipe for a painful knee. Jangir?
Yeah, I think first is use the correct approach. That by approach, I mean opening a knee and doing your approach, which you are a master at. Okay, so that's what you should do initially. Do a technique, which we all talked about in our four things on whatever technique to get it right. And get it right means osteophyte removal, correct alignment. And probably third is don't get too pushed by implant companies for marketing gains, right? Stick to a good knee, which you can say your x-rays are looking perfect. And the clinical, when the patient leaves your operating table, it's like Anup Jurani, Professor Malhotra, and Nilen Shah says that no degree of tightness, yeah, it cannot be flexed. And your bend has to be X amount, okay? That's what you aim for. And that's all you need to do. Everything else, we all have our problems. Accept it.
Thank you. Professor, your comments, please.
So, in addition to what has been said, again, what Dr. Jahangir said, make sure that your Patella is tracking well on the tracks. It's moving well on the tracks. Always keep in mind, make sure that will be one good reason to avoid, good way to avoid unhappy knee. And counseling. Talk to the patient, then only you will know what is his expectations or expectations. To me, I think if you are a reasonably good technician, the only thing where you may gain more is by counseling and talk with the patient and knowing about the patient expectations and putting them at rest, not give them undue expectations.
Thank you. Dr. Jurani, sir, your parting comments, please.
Yeah, so apart from what everybody has said, I would advise or recommend to the younger beginner people is not to get this in rat race. Of there is a lot of race in India about that if you can do the operation 15-20 minutes, that's a great thing to do. I think that's not a great thing to do at all. So don't get into that race of time of finishing the operation fast. Give it time. For you it may be 10th operation, but for the patient it's the first operation. So give it 1 hour, give it 45 minutes to 1 hour, and do all the surgical tips that we have been discussing on the last 4 or 5 seminars. Measure your amount of bone, that you cut at least that much amount of bone that you are replacing, or a millimeter more but not less, because that means that you're leaving the knee tight. So tightness is surely to be avoided. Don't speed up with your surgery. Go into the meticulous details. Handle your soft tissue with respect, and love your craft and art. I think this is what I have to say.
Thank you, sir.
Anupam, if I may just add, as
Sure.
I am a co-moderator, that that one of the thing is what Anup just said, that love your craft and art. I would add that you have to love your patients as well.
Yeah, that's right.
That only if you love your patients, they will love you back. And you have to, not only you have to behave in such a way, it has to be in it that you are doing the best possible thing under the sun for the patient. You have to behave like that, work like that, and then there is some magic which happens, and you trust your patients and the patients trust you. If anybody else wants to add any comment, otherwise I'm done whatever I had to say.
No, fantastic. Thank you. Fantastic.
Thank you.
Great.
This is a very nice meeting. Thank you all the faculties,
Thank you
Professor
very
Dr.
much.
Rakesh Malhotra, Dr. Anup Jurani sir, Dr. Nilen Shah sir, Dr. Mahalakshmi Vora sir.
Thank you.
Shall I conclude the meeting, sir?
Ashok is
Yes,
here.
yes.
Thank you. Bye-bye.
Thank you, Ashok sir,
Thank
from Ortho
you.
Thank you
Online
very much.
TV. Yeah,
Thank
bye.
you very much. That
Thank you.
was really excellent session.
Thank you,
And
sir.
I was just sitting here in the background and watching all this all was discuss and teach. I think I was learning much more than from this 2 hours than I've ever learned about this topic. So thank you very
Thank
much.
you.
Thank you
Thank
very much.
you.
Thank you, Ortho TV.
Thank you.
Thank you.
Thank
Thank
you.
you.